So I wanted to really now just to touch for a few moments on how to commission debridement into our wound care work. What's the cost of chronic wounds? Well, it's a lot of money. We know that we have an increasing amount of people with chronic wounds in the world, and that the cost of that care is going to go up. And there's some cost there related to the UK and translated into a couple of other currencies. We know that debridement is very much a basic necessity to induce functional process of tissue repair, and that's something coming from the EWMA document on debridement. And so this is now very much returning as a fundamental aspect of our wound care routines. So what are the challenges that are presented to us about debridement? And here's a range of things about the reticence for practitioners to change from what they've been doing recently, to think about all the different methods that there are out there and which one is the right one. We've got to get people trained for some of the more complex and risky of those debridement methods. We've got to think about, can you get an organization to authorize debridement, because a lot of this is being done by nursing staff and may also be done by unregistered staff. We've got to think about the pain, the anxiety that might build up for the patient because they're having serial debridements or past experience, and that has an effect and is a challenge for debridement. We've got to think about where we're doing it. Are we doing it in a clinic? Are we doing it in a home setting? And how does that affect the choices that we make? We've clearly got to think about the cost and the time available to us to do this procedure. We've certainly got to think about safety and the ease and effectiveness of what we're doing and how we're going to do that. And just getting it done, adding in additional time into already busy schedules, is a difficult thing. So those are some of the challenges. Now, in the UK, we have an organisation called NICE. It's the National Institute of Health and Clinical Excellence. And Debrisoft has been analysed by them in terms of a cost-effectiveness case. Eleanor Activa put to them a proposal to do some cost-effectiveness analysis, and they then took on that challenge, worked through the data. And in fact, some of the assumptions that the manufacturer gave to NICE about how much they felt the cost savings were actually revised upwards in terms of increased savings by the independent body that is NICE. So what is Debrisoft? You almost all know by now that it's a soft monofilament debridement pad that debrides devitalized tissue in wounds, and also surrounding the wound where you've got hyperkeratotic skin, that also is amenable to the use of Debrisoft. And it does this debridement in reduced time, and you can then produce a good patient concordance and a good patient experience. So the external economic analysis that NICE had done demonstrated against other debridement methods that you could save money in different settings. So if you compared the use of Debrisoft against a regime just using hydrogel, you could save up to between £100 and £200, depending on if you're in a clinic setting or a home. And then more money could be saved if you're using Debrisoft against larval therapy. So the total cost of savings that NICE felt were possible by introducing Debrisoft into a wound care pathway for a 100,000 population was £26,000. Now, for me, on the commissioning side of healthcare, and I have a population of about 1 million people, I could save probably £250,000 by introducing Debrisoft into routine care. And that's quite a lot. That's a big enough packet of money for me to do something else with that I wouldn't have otherwise been able to do. Very important in cash-strapped healthcare systems. And if we increase the amount of the use of Debrisoft from current practice levels in the UK at about 10% up to perhaps future practice around 50%, that's what is expected in order to get the benefits of using the Debrisoft in clinical practice, and we would consequently see a reduction in the use of hydrogel. So the likely benefits that NICE felt from using Debrisoft were that we would get full debridement more quickly, we would have fewer nurse visits compared with other debridement methods, They felt that it was easy and convenient to use, importantly well tolerated by patients, and that this debridement is an important component in the standard wound care management. So how does DebriSoft stack up against those challenges I mentioned earlier? And here I've just used the idea of a tick to say it stacks up, or a question mark to say maybe there's a good case for it. And as you can see, there's nothing there that I think it's a definite no, it doesn't assist with the challenge. So if we have reticence of care workers to use it, that depends upon the local implementation and authorization process. But if you can get that through organizations and into formularies and into wound care pathways, then we should be able to overcome that reticence to use that. So it will help you to meet that challenge. Will it help you in terms of the method? Well, we know that the use of DebriSoft is good for a variety of wound care presentations, so that's a definite yes in terms of meeting one of those challenges. You can use it in a lot of situations, both wound care and a lot of environmental location situations as well. So it's good in the home, it's good in the clinic. It's very easy from a training purpose to do. You don't have to go into complex training. You can pretty much, grab and go. Is it going to be painful or anxiety-making for the patient? This is well tolerated by patients, but it will, of course, depend upon the individual previous experience of what that patient has had as to whether or not they will have pain-induced or anxiety-induced by any form of debridement. But used from the beginning, then this is generally well tolerated. Cost, well, I've put a question mark there because we've got to ask ourselves the question, can you afford not to use something that's going to get you through the difficult inflammatory period more quickly and on to the repair process? And it's certainly simple just to plug into nursing routines. It's not going to take much time and it's easy to train. So it's really going to help you to meet those challenges. So how do we commission products into care? Well, certainly in the UK, from the birth of a particular product or the introduction of a product, we have company case studies, we have company data to start with. We then have early adopters and we have conferences and study days to share this new thing with people, to create a bit of a buzz. We then might find that it becomes of such interest that it starts to show in a guideline, like a society guideline, and that gives it a bit more profile. And then somebody like NICE will come along and say, actually, what's the noise that's creating around here? Or maybe the manufacturer will, like was the case here, be encouraged to have a look at the value of this particular new product. In terms of the NHS contract for care that commissioners have with our providers, we have a part of that contract that says that all NICE guidance that comes out from this central body must be analysed. And whilst there are different levels of NICE guidance, there are must-dos and think-about type levels of guidance. All of the providers that over there providing care must have a look at all that guidance and tell us as commissioners whether they're going to implement that or not. So that then means then that if we are then looking at, if we are wanting as a commissioner a particular thing introduced because we feel it's going to improve quality, improve safety or reduce cost, then we can encourage people to look at that as well. What then happens is that we'll find that within a clinical commissioning group we will also have a review body that's reviewing all the NICE guidance as well, so that we form our own opinion of what we should introduce. And once we've made that view, we will then work with our medicines optimizations teams who run the formularies and who interface with the clinicians in the provider organizations in order to put that into practice. And then those medicines optimization teams will then monitor the uptake of that. So hopefully then we can go from the introduction of a new product through a reasonable cascade into commissioning that product into practice. So to conclude then, the NICE committee considered that despite the uncertainty that there was in the cost model, and in fact there was going to be more savings, they felt, when they did their own external analysis. The use of Debrisoft could certainly generate cost savings compared with hydrogel, gorse and larvae. And they concluded that the case for adoption of Debrisoft was found to be supported by the evidence. So use of NICE guidance will improve likelihood of commissioning to local formularies in the UK, and that means that commissioners are putting Debrisoft onto formularies are seeking to match their aspirations for improved quality of care in a cost-restricted environment.